Hello, my name is Karey Jones. I'm a student in the RN to BSN program at MUW, and today we'll be presenting to you melanoma, which is a type of skin cancer. First, I wanted to review our objectives for you. After viewing this presentation, you should be able to recall important facts about melanoma. Also, you should be able to list the contributions of the physicians who have first encountered melanoma, and list and identify those who are at most risk for developing melanoma. At the conclusion of this lesson, the student will be able to identify the major risk factors of melanoma and will be able to list and explain the ABCDEs of melanoma. The student will compare appearances of basal cell carcinomas, squamous cell carcinomas, and malignant melanoma. The student will also be able to choose methods for diagnosis. The student will be able to list signs and symptoms of melanoma and develop and carry out a plan of care for a patient with melanoma. The student should understand the impact of the individual and family and society that melanoma has. So what is melanoma? Melanoma is a tumor of melanin-forming cells, typically a malignant tumor associated with skin cancer. It is the most dangerous form of skin cancer. Skin cancer is the most common of all cancers, and melanoma only accounts for less than 2% of skin cancer cases. But melanoma causes a large majority of skin cancer deaths. Melanoma is also 100% curable. It's only curable if it's recognized and treated early, but if not found and treated early, the cancer can metastasize to other body parts. Once metastasis has occurred, the cancer becomes more difficult to treat and can be fatal to the patient. Melanoma occurs in the skin cells called melanocytes. Melanocytes are the pigment-producing cells that give each of us our skin color and tone. When these skin cells are damaged, it triggers mutations and skin cells multiply rapidly and form tumors. So what's the history of melanoma? Melanoma is not a new disease, but it is rare in our history. One of the first examinations of melanoma was in the 1960s on examination of 9 Peruvian Incan mummies. These mummies were radiocarbon dated, which showed them to be 2,400 years old. Radiocarbon dating also showed on examination that there were apparent signs of melanoma. These signs included melanoma masses on the skin with metastasis to the bones. In 1787, John Hunter was the first to operate on metastatic melanoma. At the time, he did not know exactly what he was operating on, but referred to it as a cancerous fungus excrescens. The excised tumor was preserved in the Hunterian Museum of the Royal College of Surgeons in England. Microscopic exams were done in 1968 that showed the tumor to be an example of metastatic melanoma. French physician René Laennec in 1804 was the first to report that melanoma was a disease entity. In 1820, William Norris, an English general practitioner, was the first to present the English report of melanoma. In 1857, his later work mentioned that there is a family predisposition for development of melanoma. In 1840, Samuel Cooper made the first formal acknowledgement that melanoma was untreatable. He stated that the only chance for benefit depends upon the early removal of the disease. Today, the situation remains unchanged. Most early-stage melanomas can be treated with removal alone and is a major and beneficial treatment for the patient. Today, melanoma occurs in the United States, and this is in the American Cancer Society estimates for melanoma in the United States for 2015. About 73,000 new melanomas will be diagnosed, 42,000 in men and 31 in women. About 9,000 people are expected to die of melanoma. 6,000 are men and 3,000 are women. As stated earlier, skin cancer is the most common of all cancers, and melanoma only accounts for less than 2% but causes the large majority of deaths. Melanoma's rate has gradually been increasing for the past 30 years. Melanoma is 20 times more common in Caucasians than African Americans. The average age is 62, and melanoma risk increases with your age. But it is not uncommon in those younger than the age of 30. It is the most common cancer in young adults, especially young women. This is probably due to the importance of their appearance, which increases their tanning. So who can get melanoma? Anyone can get melanoma. Most people who get melanoma have light skin, but there are some cases in African Americans. Some people have a higher risk of getting melanoma than others, which leads to my next discussion on the risk factors of melanoma. A major risk factor of melanoma is ultraviolet light exposure. Some sources of UV rays include sunlight, tanning beds, or sun lamps. UV rays damage the DNA of your skin cells, which triggers mutations and forms tumors. Also, a risk factor to have is fair skin, light hair, easily freckling, or mold. Caucasians are at higher risk than African Americans. Caucasians with red or blonde hair are at a higher risk. People with fair skin that freckles or burn easily are at increased risk for melanoma. A person who has many moles is more likely to develop melanoma. Most moles will never cause problems, but some moles can change color, shape, and size, which could be a sign of melanoma. Family history. As with every disease, there is a family history. A person's risk of getting melanoma is greater if one or more first-degree relatives has melanoma. This includes your parents, siblings, or your children. A personal history of melanoma. If a person has already had melanoma, there's a 5% chance they will get a second one. Also, a personal history of any other skin cancers. People who have had types of skin cancers are also at an increased risk for developing melanoma. 10% of people with melanoma already have a family history of the disease. They just may not know it. The increased risk for family history may be because of shared family lifestyle, a family tendency to have fair skin, or certain gene changes that run in the family. Another risk factor can include a weakened immune system. As we all know, your immune system helps protect and fight infections, and if a person has a weakened immune system, they are more likely to develop infection or many types of cancers. So a person with a weakened immune system is at very high risk. A risk factor of melanoma is being a male. Male genders have higher risk of developing melanoma than females. This may be due to the increase of having to work outside in the sun. Since melanoma increases your risk with age, and older age, people who are older age, above 45, are at risk. Most men after the age of 45 are at increased risk. But as stated earlier, women at a younger age are at increased risk. Men who are Caucasian, older than 50, are most likely to get melanoma. Now that I've reviewed what melanoma is and its risk factors, I'm going to let my colleague review its pathology.
I'm Yshekia, and I will provide information on the pathophysiology of melanoma, the diagnosis, and the prognosis. In healthy skin, new cells develop all the time. New cells multiply and grow in orderly ways. In skin cancer, however, skin cells grow abnormally. If skin cells grow out of control, they form a mass or tumor. The most serious type of skin cancer, melanoma, it affects the cells that give our skin its color. Skin cancer most commonly affects areas of the skin that are exposed to sun, but may also develop anywhere else on the body. Skin cancer can grow as deep into the skin and spread to the rest of the body, causing serious complications. Although it can spread easily, it is curable when it's treated early. Benign or malignant. Skin tumor is considered benign, which is non-cancerous, if it is limited to a few cell layers and does not invade the surrounding tissues or organs. If the tumor spreads to surrounding tissues, it is considered malignant, which is cancerous. There are three main types of cancers. You have basal cell carcinoma, squamous cell carcinoma, and malignant melanoma. In basal cell carcinoma, you will find a pearly translucency to fleshy color, tiny blood vessels on the surface, and sometimes ulceration. It may present as a raised, smooth, pearly bump on the sun-exposed skin of the head, neck, or shoulders. Crusting and bleeding may develop in the center of the tumor. It is also mistaken for a sore that does not heal. This form of skin cancer is least deadly. In squamous cell carcinoma, it is far more aggressive than basal cell carcinoma. It commonly presents as a red, crusted, or scaly patch or bump, often a very, very rapid growing tumor. Can occur in the lining of the digestive tract, lungs, and other areas of the body. In malignant melanoma, it consists of various colors and shades from brown to black. The common appearance is asymmetrical, with an irregular border, color variation, and often greater than 6 millimeters in diameter. It can be cured if treated early. Know your ABCDEs of melanoma. A, asymmetry. One half of the mole doesn't match the other. The mole on your right is benign. The borders, it is symmetrical, borders are even. The mole on your left is not symmetrical at all. Border, the mole on your right is benign, and the mole on your left is malignant. The edges of the mole are more ragged when the mole becomes malignant. Color. Pigmentation is not uniform and may spread into the surrounding skin. If you see the mole on your right, it is lighter. Of course, the border is more symmetrical than the mole on the left, which is malignant. It's not symmetrical. The borders are a bit ragged, and the colors, it has a few more colors in it than the mole on your right. Diameter. The mole's diameter is larger than the size of a pencil eraser, which is the best way to determine if your mole is not looking normal. Just get a pencil, place it on the top. If it's larger than the end of a pencil, then it's time to see a healthcare professional and get it examined. Elevation. The mole is raised above the skin and has an uneven surface. As you can see in the picture here on the right, the mole is raised, but the border is, it has a good border and it's symmetrical. The mole on the left is asymmetrical and it looks like it's discolored. Diagnosis and prognosis. First, we want to start with a visual exam by a healthcare professional. You can also inspect your skin at home. If you find something that doesn't look right, seek some type of care with your dermatologist or your healthcare professional. Shave biopsy is also performed, punch biopsy, incisional biopsy, and imaging test, PET scan, CT scan, MRI. A shave biopsy is performed with local anesthesia. The epidermis and the upper part of the dermis are shaved off in a thin slice. With a punch biopsy, sample of the entire thickness of the skin is taken with an instrument that takes a cylindrical core sample of the skin and a small part of the underlying fat layer. Incisional biopsy and excisional biopsy. With the scalpel, a wider and deeper sample of skin with various amount of underlying fat is removed, and then the wound is closed with stitches or staples. Incisional biopsy removes a portion of the growth, and excisional biopsy is used to remove or sample broad or deep growth. A skin biopsy usually takes about 15 minutes total, including the prep time, dressing the wound, and instructions on wound care at home. You want to instruct the patient to keep the bandage over the biopsy site until the next day. If it occurs, apply deep pressure. If bleeding occurs, apply deep pressure to the wound for 10 to 20 minutes. And contact your healthcare profession if the bleeding does not stop after 10 minutes. All biopsies cause a small scar. Try not to bump the biopsy area or do activities that might scratch the skin. Healing of the wound can take several weeks, but it is usually complete within 2 months. Wounds on the legs and feet tend to heal slower than those on other areas of the body. You want to make sure you wash your hands with soap and water before touching the biopsy site. Pat the site dry with a clean towel. Cover the site with an adhesive bandage that allows the skin to ventilate. Continue caring for the biopsy site until the stitches are removed. For shave biopsies that don't require stitches, continue wound care until the skin is healed. The prognosis depends on the stage of the tumor. Outcomes are best for patients with early stages of the disease with small tumors, no spread to lymph nodes, and no distant spread to other organs. Outcomes are also better for younger patients. Survival for squamous cell carcinoma is better. Now I'll turn it over to the next presenter.
I'm Chaquana Bohanna from MUW BSN program. I'm going to speak to you about some ethical issues. My colleague Karey kind of went over it, but I'm just going to touch on it again. Men, there are white men and black men that are exposed to melanoma, as well as Hispanic and Asian Indian men, Alaskan Native American men. However, white men is more prominent in white men. CDC 2011 did show that black males their numbers are increasing as well. Also, women are exposed, but men are more prominent. Women, white women, black women, Hispanic women, Asian, Indian women, Alaskan Native women as well. The impact of melanoma on individual, family, and society. Financial burden. That can be a huge barrier. Melanoma can get pretty costly with the treatments and everything. Not only that, depending on the staging, you may not be able to work. Therefore, your family may become financially burdened. Fear of the unknown is scary. You don't know what to expect. Encourage support groups. There are several support groups out there for cancer patients, not just melanoma, any type of cancer. Your attitude in cancer. Attitude plays a huge factor in it. If you have a positive attitude, a lot of times your outcome is better. coping with cancer. Coping is different just depending on the individual. Everybody copes differently. Coping with the loss of a loved one, depending on what stage it is, it can even, cause death. And everybody copes again differently, depending on the individual. The impact of melanoma, I'm still discussing that. How readily accessible is the treatment? It's pretty accessible depending on the stage. The stage 0, that's surgery is pretty much an option for any stage because we want to get rid of the melanoma so that it doesn't spread to other organs, metastasize. Radiation is also an option for stage 0. This is a case for me. Quidmot cream, it's a cream that several dermatologists use for melanoma. Stage 1, surgery again is an option. Sentinel lymph node biopsy, lymph node dissection, adjuvant treatment. Stage 2, surgery again, you see surgery again. And you also want to biopsy it again in stage 2 with the adjuvant treatment and the interferon. Other drugs and vaccines are available as well. Stage 3, clinical trials. In stage 3, sometimes they do clinical trials, radiation again, chemo, targeted therapy, immunotherapy, and chemotherapy. They also do a combination of immunotherapy and chemotherapy combined, which is a biochemotherapy. As you can see, as they get more aggressive, there are more treatments for it. Stage 4, you see surgery again. Surgery, radiation, immunotherapy, targeted therapy, chemotherapy, and again, clinical trials. The cost of it. Okay, approximately $2.3 billion is spent on cancer for melanoma. That's huge. 65% of the cost is being spent on continued care. About 21% on the last year of life. About 14% on initial care. So again, we want to try to catch it in the first stage before it gets aggressive. If it's diagnosed early, a dermatologist removes the melanoma for about $1,800 per patient. But as it progresses, the cost goes up. The treatment cost solar as melanoma advances rise to $170,000 per patient at the later stages, and it accounting for 90% of the overall melanoma cost. So again, prevention, we want to try and prevent it. Will the insurance company pay for it? Will it cover it? Most of the insurance companies does cover it. Chemotherapy is what they cover, most of them. But some of the private companies are deciding not to pay for some of the chemotherapy drugs. However, there are patient assistance programs depending on income. That's always a factor. And possibly even Medicaid for the low income. How does melanoma affect the normal life events such as your education, your marriage, having children? Well, one of the things is if you have melanoma, it's probably going to affect you in several different ways. Education, you probably won't complete it right then because that's your least worry. You're worried about your melanoma. So it's, you're probably going to put that off until a later date. Will I get married? You may not get married right then because you're so afraid because of the fear of the unknown. That's something that several people put off as well. Will I have children? Good question. You don't know, especially with females because of the chemotherapy drugs. that can hinder that. And just depending, some people just wanna put it off until later, even meals, because they wanna find out, what's gonna happen in the end. There's support groups. Here's some of the phone numbers and the websites for the support groups, but there's several out there. You can always just go online and Google support groups for cancer patients. There's several out there. The plan of care for melanoma. The problem is you can have infection. You can get diarrhea. Some of the medications cause it. That's a side effect. Inadequate nutrition, fatigue, constipation, skin integrity. Remember, melanoma is a skin cancer, so that can be interrupted as well. Altered oral mucosa from the chemotherapy drugs, that can be a factor. Altered sexuality patterns. Some of the side effects may impede that as well. Or maybe just your self-esteem, you have skin cancer, so that may be a problem. The altered family process, you just don't know how it's going to affect each family. It affects you differently. It's individualized. Everybody copes differently. Plan of care of melanoma, infection related to immunosuppressant. Remember, your immune system is suppressed, so the patient may get a fever, but our goal is to remain a febrile, meaning without a fever. We want to try and wash our hands with warm soapy water. That's going to help decrease infection. We want to wash as much as possible. And especially when you're going into hospitals, you want to try and wear a mask. So many germs in there. But again, you can't wash enough. Just remember to keep washing. Diarrhea related to irritated GI mucosa. Again, because of the chemo and the radiation. We want to try to encourage fluids. We want to keep our vital signs stable. We want to, if you don't get a lot of fluid in, that can affect your vital signs. We want to keep a more mucous membrane, good skin turgor, all this. But remember to drink as much fluid as possible. We want to encourage that. Adequate nutrition related to poorly controlled pain. We don't want pain to be a factor. We want you to have stable weight. That can also aid in malnutrition, which we don't want that. So be sure to verbalize your pain so that you can get pain relief. We want to encourage opioids and relaxation therapy. We don't want, that's what we want to do. We want to keep you comfortable. Fatigue related to altered body chemistry and chemotherapy. The patient will improve the sense of energy. We want to encourage the patient to perform their ADLs and participate in desired activities at levels of ability. Constipation related to poor oral intake. We just mentioned that. We want to make sure that you maintain a usual bowel consistency or pattern. We want to encourage a minimum of 38 grams of fiber per day, 8 glasses of water, maybe even get some walking in if you can tolerate it. The patient, we want you to verbalize understanding of factors and appropriate interventions and solutions related to individual situations. Again, we want to encourage oral intake. This is a list of our references that we have used for our project, and I do want to thank you for being such a great audience.